Hey folks, Scott Weingart here, and this is the EMCrit podcast. Specifically, it is the cardiovascular EMCrit podcast, which means very shortly we will be joined by Trina, who is the master of all things cardiovascular EMCrit. Today's episode is on differential oxygenation and ventilation during VA, veno-arterial ECMO. Now, normally on these mechanical circulatory support episodes, I will tell you, there's something here even for people who do not do ECMO. They are not, as I like to call them, pump heads. There's still something to learn about physiology, about how respiratory dynamics work, all of that stuff. Not this one. If you're not doing ECMO, then today's episode is going to have no real relevance to your life. You are probably better off just skipping it. Now, I will tell you, because there are these doubters out there that every time I post an episode like this, they're like, I didn't sign up for this. This is not, bread and butter, emergency medicine, critical care, or resuscitation, or acute critical care. This is a bonus. The regularly scheduled episode will be there on Thursday. This is not taken away from that. This is not stealing your joy. This is not eliminating space for what could have been an episode directly relevant for your practice. So don't worry. If you're on Reddit, who tells me all of my episodes now are on meditation. There's been exactly one episode on meditation in all of EMCrit, and it was at a clinical conference. That's where the lecture came from. But be that as it may, if you're a pump head, listen. If you're not, you're more than welcome to listen, but there's probably not too much of relevance for your life if you're not working with patients on VA ECMO. And with that, let's get into what is an extraordinary episode for those folks that are interested in all things ECMO. All right, I am joined again by Trina for CV-EMCrit, and specifically in MCS, a Mechanical Circulatory Support Minute. So what are we dealing with today, Trina?
One of my favorite topics, we get to talk about gas exchange on peripheral VA ECMO.
I actually love this, as you know, because you were a faculty member last time around, and you'll be this time around for R10 coming up. I love this stuff, and this is the stuff that I really love to delve into. And you can't get a more interesting topic than how to manage a vent on a patient who has two circulations. So I'm going to let you run away with this, Trina. Tell me where we should start.
Perfect. I think we should first start by explaining why this is important and how it's different from VV ECMO and gas exchange on VV ECMO.
All right.
And I bring that up because so many times I'll have one of my trainees walk up to me and be like, oh, well, I don't have to worry about gas exchange. They're on ECMO. And I'm like, yeah, no, it doesn't quite work like that. This is VA ECMO. So we think it's really important to remember that when you're talking VV ECMO, we're talking two circuits in series. And what do I mean by that? So patients have their native circulation, and then we also have our ECMO circuit blood flow. On VV ECMO, if you think the most standard configuration, we're talking someone who has a drainage cannula sitting at their cable atrial junction and likely a return into their jugular vein that then is sending blood back to the superior vena cava. These patients, that well-oxygenated and decarboxylated blood comes back to the atria and then is going through the heart and the lungs, mixing with their native flow, and is ejected as a homogeneous blood flow to the whole body. So truly, when we're talking gas exchange on VV ECMO, we're managing it with the ECMO circuit. And that's why we can do rest settings on those patients, where you can truly allow their lungs to rest. VA ECMO is quite a bit different, and specifically in this episode, we want to talk about peripheral VA ECMO. So with peripheral VA ECMO, the standard configuration, especially in ECPR, is going to be a femoral configuration, where you're going to have your drainage cannula sitting typically by cable, so draining from the superior vena cava, inferior vena cava, and the right atrium. And then your return is going to sit in the femoral artery and most likely end in the iliac artery. So you'll have all that blood going retrograde up the aorta. But if you think about it, no matter how good your drainage is, you're not going to drain all the blood in the right atrium. So you're going to actually have blood going through the heart, through the lungs, and eject it. Now, depending on the patient's cardiac function and other factors, there might be more or less blood going that way. But there is going to be a portion of the body that it is going to see blood that was ejected from the heart and through the lungs. And so the native cardiac and lung function is really going to influence the oxygenation and ventilation of that blood, whereas the blood that's coming from the ECMO circuit is going to be influenced by your membrane oxygenator, your sweep gas. And where that area meets is called the mixing point. Most people are familiar with that, but we forget that we truly have two circuits in parallel. where these two different areas of the body are seeing completely different gas exchange, not only oxygenation, but also carbon dioxide levels.
Oh, it's perfectly stated. Wonderful. I often like to think about this as VV-ECMO being a circuit in confluence versus VA-ECMO, which is a circuit in opposition. You have butting heads, and where those butting heads actually wind up fighting it out could be the difference between a perfused brain, a perfused heart, and one that isn't. And so that's really why it's a more interesting and difficult physiology in VA-ECMO.
100% agree.
All right, where do we go next?
So I think it might be important to break this gas exchange down just a little bit more. So I feel like people are really familiar with differential hypoxia, or otherwise known as north-south syndrome or Harlequin syndrome, where people are very familiar with kind of the classic ECPR patient. You put them on ECMO, they start having native cardiac recovery, or you put an vent in, an Impella, and suddenly they have antegrade cardiac output. But unfortunately, their lungs have taken a beating, whether it's severe pulmonary edema, they have aspiration pneumonitis, you gave them big pulmonary contusions from your great CPR. But either way, they have impaired gas exchange. What happens is those patients will end up having hypoxemic blood going out and being what the body sees that's proximal to that mixing point. And typically, if you think of your mixing point, it can be anywhere, but say it's in your descending aorta, you end up with your brain and your coronaries seeing this hypoxic blood, while the blood coming from your ECMO circuit might be well oxygenated and the lower part of the body is being well oxygenated. What I find that people tend to forget about is differential carbon dioxide levels. And interestingly, I actually paused when I was creating this podcast because I thought I did a targeted cardiovascular critical care fellowship and a year of ECMO training, and never once did one of my attendings bring up this topic. Now, I'm sure they were thinking about it and very cognizant of it, but no one ever talked about it. And so I think this is something we really need to talk about. So the reason I bring it up, and I think it might be easier if I illustrate its importance with a case, if that's okay.
Please.
So I find that this is something I see all the time. So I'll be rounding on a patient. Imagine you have this patient, they were a STEMI out of hospital. They actually arrested, EMS brought them in, they activated pre-hospital. You cannulated them in your bay for ECPR. They went to the cath lab. They ended up doing a heart cath, were able to intervene on the culprit lesion, and the patient comes to your unit. A classic story, right? Typically, they end up getting a decent amount of resuscitation. They have increased capillary leak, and they get volume overloaded. But the patient's heart function starts getting better, and they're ejecting decently. And you walk on 3 days later, and they have a pulse pressure of 30. They're still in the vent because their neurostatus is still taking time to recover. And you look at the gas in their right upper extremity, and you see your gas is like 7.56, PCO2 of 47, your PO2 is 130, and your bicarb is 39. And you turn to your resident and you're like, hey, what do you think about their significant metabolic alkalosis? And they say, oh, you know what, we're diuresing them with Bumex, and we're just contributing it to a side effect from that. And people just keep going. And you pause for a minute and you're like, but I noticed their sweep gas is at 1.5 liters and no one has checked a post-oxy gas in like a long time. And I'll say, hey, we didn't check the post-oxy gas. And they'll say, oh, Dr. Augustine, their oxygenation is perfect. I'm not worried about it. And I'm like, yeah, but what about their ventilation? What if on that gas that your perfusionist checked yesterday and you never looked at it, their pH was 7.26, PCO2 was 65, PO2 was 130 on fraction inspired oxygen of 60% on your circuit, and no one saw it. But suddenly your kidneys were seeing this hypercarbic blood, basically a respiratory acidosis due to inadequate sweep gas, and no one caught it. Suddenly the kidneys are getting smart and they're saying, I better excrete hydrogen ions and reclaim bicarb. And you now have a metabolic alkalosis that's actually affecting both circulations. So while you have those two circulations that are working in parallel, they are still very interdependent.
That's a fantastically elucidative case. And I think it's going to go into some of the practical recommendations that are going to come shortly. When I think about this, the amateurs to ECMO just think, okay, they're on ECMO, everything's going to be fine, right? And they'll sometimes be right if there's not bad lungs or if there's not a circumstance like you just mentioned in the case. The intermediate folks are the ones you're talking about. They're like, I need to monitor for a hypoxemia. And they're the ones who are going to be really diligent about finding a pulse ox in that right upper extremity. measuring blood gases there. But the experts are the ones that understand it's not just an oxygenation issue, it's a ventilatory issue as well. And you're absolutely right. I've seen post-ox blood gases just fall off the table when everyone looks at the right upper extremity blood gas and says, looks good, all's well in the world. And that's, I think, really what you're hitting here. Trina, is that right?
Absolutely. I love it.
All right. So where next?
I think the next thing that we can talk about is the important steps that I go through my mind when I'm looking at these patients. And the first thing that I look at is monitoring. It's really important, and we've mentioned this multiple times, to make sure that you're checking a right upper extremity ABG. Pulse ox on the upper extremity is also great. Basically, you want information from that area. And as most people are very aware of, this is because you want to sample blood that's coming from that innominate artery. That's your first branch off the aorta. Remembering that your coronaries are actually more proximal. But you want to sample that because we use that kind of as an approximate of what the brain is seeing. Now, it's a little nuanced. If your mixing cloud is in the arch, maybe it's not perfectly what it's seeing, but it really gives you a pretty good idea. I do caution people to use caution when saying, if my right upper extremity A-line has great oxygenation, that my coronaries are great. Because if you look at your A-line and suddenly you have a minimal pulsatility, you throw your bedside cardiac ultrasound on and you see barely any ejection, or your aortic valve is minimally opening, think that you might actually have a very proximal mixing cloud, and potentially your coronaries could actually still be seeing hypoxic blood. But as a poor man's surrogate, looking at that right upper extremity ABG or pulse ox, that's a good place to start. But you can't stop there. And that's where I see it stop. I see these people with awesome protocols. They check ABGs, Q4 hours, Q8 hours, or whatever. And it's all coming from the right upper extremity A-line. And then I'm like, but what about your post-oxygenator gas? And they're like, we don't need to check that because we know we have good oxygenation. And I'm like, I get that. But what about the ventilation component? So it's really important. And I want everyone to really remember that when you're checking a post-oxygenator gas, you're not just looking at the oxygenation. You're looking at the ventilation. So what I tend to do is I'll check ABGs every 4 to 8 hours. It depends on how unstable the patient is. And once they're very stable and I'm not making any additional changes, you can stretch those out. One of the things to think about is if you're making vent changes, you're making sweep changes, you're making flow changes, or they suddenly get septic and they have an increased metabolic demand. So you really want to think about any changes and make sure that you're altering your ABG schedule to that. But I want to enforce it's not just right upper extremity, it's also post-oxy gas. After that, I move into step 2, where I'm making sure
let me pause you on step 1, Trina, before you go on, just to really lock this down. So the patient's stabilized, you're not making any significant changes. Are you getting a right upper extremity and post-ox gas every, Q12, Q24 hours at that point? And if so, are you doing the matched pair each and every time?
So I love it. No, I'm not doing the matched pair each time. Once someone has stabilized for me, I tend to switch to right upper extremity ABGs about every 12 hours. And then I find for the circuit, as long as there was no sweep changes and I feel like their metabolic demand has not changed, I'll switch that to Q24 to even Q48. I have no problem with that being a Q48 hour check as long as there hasn't been any significant changes.
All right, fantastic. All right, go on to step 2, my friend.
So step 2, I try to elucidate where is the mixing point. And you can get fancy and you can put a TE probe in and you can actually look for bidirectional flow and turbulence. But most of us aren't going to do that each time. So I tend to use my ABGs to help elucidate that. And sometimes it's simple. Sometimes you get your post-oxygenator gas and your PaO2 is 400 and you get that right upper extremity ABG and your PaO2 is 85. And you know that your mixing point's in between there.
Hey folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So Go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Other times it becomes a little bit more complex, but sometimes those are the times that it doesn't matter as much. Maybe your lung function is actually pretty okay, and you're not really at risk of having differential hypoxia. So it doesn't matter quite as much. But I encourage people, use your ABGs, use your bedside cardiac POCUS, and your arterial line hemodynamics to help figure out where that is. Because if you look at a patient that has basically a straight A line with minimal pulsatility, and you don't have much of a vent in, or you put the probe on and that their heart's barely squeezing and the aortic valve's not opening, you're going to have a pretty proximal mixing point. And then vice versa, when you walk in the room and you got pulse pressure of 30 and the aortic valve's opening with every beat, they have recovering cardiac function, you're going to have a more distal point. And so I think it's like everything in medicine. You can't use one data piece in isolation. It's use every tool in your toolbox at your disposal.
All right, so let's assume you have a mixing point that is distal to that arch. So now, therefore, you're worried. What is now our next move?
So then my next move is make sure I have adequate gas exchange in both circulations. So here is where it gets complex, because I say the easy part is the circuit. You can micromanage that to your heart's content. You can adjust your sweep flow, your FDO2, so the fraction of inspired oxygen, and your sweep gas. To a certain extent, you can adjust your flows, but remember, that's your hemodynamic support. So on VA ECMO, you're really not going to be cranking that up or down too much based on oxygenation. The more complex part becomes, how do I manage the native gas exchange? Because this is challenging. And for people who've done this before, they can tell you this is where everyone starts to sweat a little bit. So sure, I can just put another cannula in. And as someone who loves to put cannulas in, I get that. But I do try to subscribe to maximally thoughtful, minimally invasive critical care. And so I always think if there's something else that we can do, it's important. So for me, that's first of all sitting down and saying, how can I optimize their lung function? And remember, this is a little different than VV ECMO. I feed into my trainees all the time that when you have a VV ECMO patient and they're having worsening hypoxia, it's not flog the lungs, or sure, you can still try to optimize lung function, but really you're not focusing on the lungs, you're focusing on the circuit. On VA ECMO, it's a little bit different. Here, I'm diuresing, doing my best to dry those lungs out. If it's a pneumonia, I'm treating with antibiotics. I'm doing all of the therapies to make their lung tissue better. But also, I'm taking a look at their vent. Now, I'm very focused on maintaining lung protective settings. If I'm unable to do lung protective settings, then I am going back to, do I need an additional cannula or an ECMO reconfiguration? However, there's many things that we can do on our mechanical ventilators to optimize their oxygenation. And we're all used to doing that in critical care. We're used to optimizing our mean airway pressure. And maybe that means optimizing PEEP first to get to your FRC, your functional residual capacity. Or maybe it means in burst ratio ventilation, increasing that I time, going to APRV, which I know that you love, Scott. And I have to say, I love it too. There's so many people who are like, they're on ECMO, we can't do that. And I'm like, oh, you can definitely do it. And you can do it lung protective. But really, my point is there are many things to look at before you just jump to putting in either an IJ cannula and doing a VAV configuration, or doing kind of a sport model of VA ECMO where you have a return in the subclavian artery so that you're ending up with a more centralized return of well-oxygenated blood. So I really want listeners to know is there's options, and good critical care is integral in this problem.
All right, let's really delve in a little bit deeper to this, because there's so much fascinating stuff. And I will just say I completely agree with you. The tagline I use is a simple circuit is a safe circuit. So jumping to hybrid just increases my potential problems on these patients. So if we can avoid it, let's do it. Oxygenation and ventilation need to be separated in terms of our strategies here. And I know, because I've spoken to you so much, that you, like me, are a fan of having a recruited lung set with these patients. And that's going to help us on the oxygenation side. And we could really overcome bad lungs by having a thoughtful management of this patient's. Primarily, it's their PEEP. It's their mean airway pressure that matters in this case. And I see like the routine that I start with, which is 10s all around, a PEEP of 10, et cetera. That's like for the first 10 minutes. And then we figure out, have we recruited the lungs or not? You can't leave them there. And this is another amateur mistake is, they're on VA ECMO. We don't have to worry about the lungs. No, you need recruited lungs. So that stuff I think makes sense. I'm more curious about the ventilatory side, because oftentimes we'll leave these patients on relatively low tidal volumes and low respiratory rates. Trina, do we really need to care if the patient's brain is good? If we have the situation where their circuit flow has a normocapnia, but their native lung flow is hypercarbic?
Oh, so that's a tough one. And it's interesting because I was thinking about this because there's so little data on all of these topics. In fact, I had one of my surgeons text me like 48 hours ago and they said, "Hey, what's the data behind this topic on VA ECMO?" And I'm like, first of all, we don't
Data?
have much
What's
data that it works. And then two, on the micromanaging things, there's no data. What's interesting though is we don't have a ton of literature out there. We do have some consensus statements and some experts who have looked at what they recommend in patients like post-ECPR. And typically these are patients who are on peripheral VA ECMO. And they really push that it's important to not have hypercarbia or hypocarbia. And they shoot for that PaCO2 of 40 to 45. Now, I think this is interesting because there's actually a recent publication, and happy to link this to our show notes too, that actually looked at the incidence of microbleeds in some of these patients. And there is some concern that if the brain is seeing hypoxic, hypercarbic blood, it will actually increase blood flow to the brain. And these patients often have kind of this increased vascular permeability. And those things together sometimes are the perfect storm, especially when you add anticoagulation on, and they end up with potentially an increased risk of bleeds. I do have mixed feelings. I do try to avoid significant hypercarbia. You bring up a point. If they are neurointact and they are following commands and doing all of these things and their RV function is pretty good, then I don't feel quite as strongly, especially not if it's allowing me to stay lung protective on their ventilation.
All right, I like that. And I think as soon as we posit ECPR, then we are talking about brain injury. So a more tight management. Now, I will put out there, and I think you agree with this, and you'll correct me if I'm wrong, but the other mistake to make is to take a patient who was profoundly hypercarbic during their prolonged arrest and rapidly bring them down to even close to normocarbia. And we do have data for that as well, albeit retrospective, but rapidly changing these patients from a hypercarbic milieu to normocarbia or capnia, I don't know why those two are not the same word and in their normal usage, but be that as it may, is a fantastic way to mess up these patients' brains. I certainly would love to see that 38 to 45 range eventually, but not quickly. And are you in agreement with that, Trina?
Could not agree more. In fact, this is one of the things that I will like very clearly, and I like a very calm room when I cannulate, very peaceful, very quiet, where it's just the ACLS leader and me speaking. But that is one thing that I will turn and with very closed loop communication say to my perfusionist, hey, we're going to go on at 2 liters of flow and a sweep gas of no higher than 2 liters. And please don't make any adjustments until we have seen our first gas, and then we'll talk about it. Because really, especially on those incredibly hypercarbic patients, you're creating quite a delta. If you have sweep gas with a CO2 of 0, and suddenly they have a PCO2 of 120 because they've been down for a while, you really don't want to go on with a sweep gas of 5 or 6 and drop that CO2 quickly, because definitely it's been linked to increased neurological complications. And I'm pretty sure both you and I have probably seen that. I've had the very well-meaning perfusionist be like, hey, I have their sweep at 7. And I'm like, great, they corrected in 25 minutes. Not great.
Great. All right. So far, what I'm hearing is, first of all, be aware that you have to worry about differential ventilation as well as oxygenation. So that means get post-oxygenator gases even after you've started monitoring right upper extremity. So far, I'm hearing that we have to make sure we have an open lung, a recruited lung. And now I'm hearing that it matters in some patients what the differential ventilation actually is. Now, let's talk about how to get there. You are advocating low tidal volumes empirically on these patients. Less than or equal to 6 is, I believe, what the post says. So does that mean you're adjusting your respiratory rate as the sole parameter to get native effects on the patient's CO2?
So typically, yes. And one of the things to kind of preface this is I tend to target very lung protective settings. So for me, that tends to be around 6 mLs per kg or less. So not ultra lung protective, which I tend to more target on VV ECMO. But typically, I find that I don't have a ton of problem with that, but it might be because of something else. So if you think about it, when you put patients on VA ECMO, what are you doing? You're really redirecting a significant amount of their transpulmonary blood flow that you're actually stealing. So you're creating this massive shunt. And when we decrease the blood flow to the lungs or decrease the perfusion, you really end up needing less minute ventilation, I find. So it's all about matching ventilation to perfusion. So typically I find that if I'm using tidal volumes of 6 mLs per kg, that I can actually stay at a very reasonable respiratory rate and still have adequate minute ventilation to meet their perfusion. Now, I'm someone who does flow high flow VA ECMO. So I'm typically over 4 liters, sometimes even closer to 5, but definitely 4 liters and up, unless it's a special scenario. Maybe if it's isolated RB failure or peri-procedural, it'll be slightly different. So with that, I find that 6 mLs per kg tends to be enough. Now, if it's a patient that has beautiful looking lungs, they don't have massive pulmonary edema, ARDS, anything like that, and they are awake and they want a little bit more, rather than having ventilator dysynchronies or patient self-induced lung injury, I might let them have a little bit more. But ultimately, I'm trying to stay lung protective with their plateau pressures, their driving pressures, minimizing massive tidal volumes and things like that.
All right. And some people subscribe to this. I'm curious to hear where you live. The teaching when I was in critical care fellowship was it is your plateau, it is your tidal volume that matters, but your respiratory rate really doesn't. You could give them as many breaths as you could fit as long as there's no air trapping. And now the new thought is that it's actually multiplicative, that maybe respiratory rate, like how many times it gets whatever driving pressure, albeit a safe one, it is actually a problem as well. Which camp do you live in?
So I 100% realizing that this is a data light zone. I'm a firm believer in minimizing mechanical power and my driving pressure. So I totally believe that respiratory rate matters. And to me, it just makes sense that if you are exposing the lung to injurious forces, the more often you do it, the more harm you're going to have. So, as I'm perfectly trying to target my minute ventilation to their perfusion, my goal is to minimize their respiratory rate. And for most patients on VA ECMO, I find that I can do that with respiratory rates of 14 to 16, and I'm actually doing fine. Sure, it's not the ultra protective like in VV ECMO where I'm like 4 to 12, but I can still do pretty good. I'm normally not sitting at 30 breaths a minute. If I'm at 30 breaths a minute and having that much issues, that's again where I might start thinking, is it time for an ECMO reconfiguration?
All right. What haven't we hit, Trina?
I love this. I think that we have hit most of the big important topics. I would just tell listeners, the big important thing to do is if you have those ECPR patients and they were initially put on rest settings at 10, 10, and 10 on pressure control ventilation, that's not wrong in the fact that sometimes it really works. And I joke that sometimes it works because you really decrease their transpulmonary blood flow so much that they can tolerate a very decreased minute ventilation, especially if it's not someone that has the whiteout in their lungs and they don't have that much physiological dead space. But remember, just like you said, that is just a starting spot. It's really important to come back to bedside and look at that vent and say, all right, what is optimal for this patient? What PEEP is going to get me to their FRC to maintain those lungs open? What is their adequate minute ventilation? And really target it. Like many other things in critical care, this is not a set it and walk away. This takes a lot of kind of cognizant effort.
As always, Trina, this has been fantastic. And as always, what we've said verbally in no way will match what you have written in your beautifully crafted posts. So as always, you need to go and check the show notes for this episode. Anything else you want to say before we bid this podcast adieu?
No, it's been great being here again, Scott. Always a blast.
All right. Fantastic, Trina.